Hello, welcome everybody. Good afternoon and good evening or namaste to all of you who have actually joined this MeHeLP India Foundation uh, international webinar on this World Health Day. Our theme is actually an important theme of no health without mental health. So very warm welcome to you all. And I hope you will be able to actually partake in this interactive webinar. You have an opportunity to actually ask questions or raise comments through the chat box or question and answer box. So feel free, sit back and relax and join us in this discussion and make it as vibrant and as useful and as connected as possible in both in the UK and in India audience. I am Raghu Raghavan. I'm a professor of mental health at Montfort University in Leicester, and I'm leading the MeHeLP India Foundation, which is actually an NGO now at the moment, aiming to promote mental health literacy in urban and rural India. At the first instance, we also have a large Indian diaspora in the UK. We are also aiming to promote the mental health literacy in the UK context as well. We have a distinguished panel in today's webinar, a truly international panel from UK and India. So I would like to have a brief welcome them, and then I'll introduce them each and every one in a minute. So welcome, Professor Angie Doshani. Welcome, Mr. Paul Illingwoth. Welcome, Dr. Anjali Viswanath, and Dr. Professor. Welcome, Professor Sam Manickam to the webinar. So let me just briefly say about mental health literacy. Our aim is actually promoting mental health literacy in urban and rural contexts, and that's what we have actually done through a major project in India over the last 3 to 4 years. The pandemic is still with us. Mental distress is still with us. There are a lot of other issues that are actually happening around us as well, both nationally and internationally in terms of context. All those things actually amount to how we actually construct health and well-being, and hence the aim of no health without mental health. Mental health is not just mental health awareness. Mental health is more about how we are actually aware about the condition and how we construct that well-being and how we lead a successful life despite all the limitations, difficulties, illnesses, or disabilities that one might actually have. So health is not just the absence of illness, and mental health is also not just the absence of any of these symptoms at all. And well-being is much of a broader context as to how we live successfully with all the limitations that one might actually have, and all the conditions or other and illnesses that one may actually have as well. So it is within that context that we want to actually try and focus this webinar. And mental health literacy mainly looks at the kind of 6-7 dimensions of things: understanding of the conditions that might be prevalent, mainly anxiety, depression, and many of the other conditions, and the kind of causes, what are the triggers that for those conditions, and the kind of self-help approaches that can be applied, both in the prevention of those distress and also in promoting better mental health with or without that condition. And then in terms of what kind of professional help is available, and how we actually can access those professional services, and the kind of awareness about that, and how we eradicate the stigma around mental illness, and also the kind of information, what kind of information we can actually have access to, the right good information. I know there's a lot of wrong information or a lot of junk information around things. But what is the right kind of information that we can actually access? And then finally, how does culture actually shape our thinking and attitude and cultural values and norms, and how it actually influences us in terms of accessing our health or mental health services, and also our understanding about the whole thing as well. So I think culture is very much important to us. It is not just a way we actually look at purely from a medical model. I think I keep on saying that we must be very careful in not over medicalizing our own emotions. And I think it's important that we actually try and look at that without no judgment. And I think try to look at that from an independent, broader spectrum of looking at medicine and cultural values and traditional healing approaches and any other kind of approaches that might actually help a person to lead a successful life. So that is where we're coming from. That is an introduction in relation to what we think about mental health and well-being. So let me take this opportunity now then to introduce our panel. Our first panel member is Professor Angie Doshani. Angie Doshani is a friend and a colleague from University Hospitals NHS Trust in Leicester, very close to where I work. And Angie is a consultant in obstetrics and gynecology at University Hospitals NHS Trust, and she contributes to the well-being of women's health locally, nationally, and internationally. She strives to provide healthcare of the highest quality to her patients, continually innovating, evaluating, and implementing good practices, and has played a major strategic role in embedding a culture of safety and quality across various organizations. She leads a program of research into ethnicity and health, working with a unique population mix of in Leicester. We have a large South Asian community and also other ethnic communities as well, and of the healthcare in women's and healthcare in women's health. Her current research work aims to understand and in turn reduce the inequalities in health in Black mothers, improving their perinatal outcomes, including mental well-being, and providing efficient and culturally sensitive care. Her passion for education has led her to take on various roles within undergraduate and postgraduate medical education, with the aim of ensuring that we provide quality education to develop doctors and are skilled and competent to deliver the care that is required for current and future health needs. She is currently the head of Year 3 at Leicester Medical School, UK, and is responsibility of providing overarching leadership for students in the third year, supporting their professional development. Professor Doshani has also embarked on building a coaching culture within her organization. The aim of these coaching conversations is to help improve well-being, reduce burnout, and support doctors and other healthcare professionals to have a productive, happy career. Welcome, Dr. Angie Doshani, to this webinar, and very pleasure to have you on board with us, and also thank you for joining us in the kind of busy schedule that you actually have.
Thank you very much, Professor Raghavan. This is very flattering. Absolute honor to be part of this panel.
Our second panelist is Dr. Anjali Viswanath from Calicut in Kerala, in India. Dr. Anjali Viswanath is actually a friend of MeHeLP. She has actually been in part of our MeHeLP dialogues and conversations in the past. After completing her medical degree, Dr. Anjali did her post-graduation in psychiatry at the Government Medical College in Thrissur in Kerala. And she has also qualified D&B in psychiatry from National Board of Examinations. And currently she works as a consultant psychiatrist in Star Care Hospital in Kozhikode in Kerala. Very warm welcome to you, Dr. Anjali, to this international panel. And I know you're very busy, and thank you very much for joining us.
Thank you very much, sir.
Our third panelist is Mr. Paul Illingwoth, a friend and a colleague from my own university, at Montfort University in Leicester in the UK. Paul is currently the head of Leicester School of Allied Health Sciences at Montfort University in Leicester. He's originally qualified as a general nurse and has moved on to and trained as a mental health nurse. He has worked in hospital and community settings before becoming a mental health nurse educator. He has worked in higher education, the National Health Service, and the England and Wales Her Majesty's Prison Services. He remains passionate about mental health generally, and he's much interested in global mental health, and is also destigmatization of the mental health stigma, and also promoting equality. Very warm welcome to you, Paul, to this webinar. And our final panel is Professor Sam Manickam, who is very familiar face in the Indian context in the field of psychology, a renowned psychologist in India who actually has worked in a number of organizations, including MHAT, where he has actually had an opportunity to train a number of psychologists and medics and others. And he currently works with the Mental Health Action Trust, which is actually a well-known NGO that functions at Connecticut in Kerala. Very warm welcome to you, Professor Manickam. Now, we have what the plan is that we would actually, every panel member would actually pitch for about 5 minutes that topic of their own interest, and then we will actually enter into a discussion mode of things. So, where shall I go first? Shall I come to you, Dr. Angie, first, and then we can talk about. She's going to talk about the I think the mental health of medics and medical students.
Thank you so much, Raghu. So I'm going to talk about something that I'm very passionate about, and over my years. So I'm going to put my disclaimer out. I am not a psychologist or psychiatrist by background. I am just a shop floor clinician, but an educator, and I'm hoping that people in the audience will be able to hopefully understand where I come from. And so what I'd like to pitch for would be the burden of mental health and mental well-being in the NHS workforce. And it's really interesting that, we with time have got better at having mental health conversations with our patients, but we're still not very good at having those conversations with ourselves or with our colleagues. And when I was looking at some of the data to talk about, it was just fascinating to see how much mental health costs the NHS. And, I'm going to put a number out there, and you may want to disagree with this, but this is statistics, is that the lost working time due to poor mental health of the NHS workforce, and I talk across, not just doctors, I'm talking nurses, allied health professionals, physios, even your secretarial staff even, it's 150 million pounds. And that was in 2021. Now, if you think about it, 150 million pounds, what kind of care could it provide? And it's not just about money. It's about people, and people who have spent their careers doing what they love. Some of the very senior colleagues of mine who are now at that stage of being burnt out, stress, having to take time out of careers. And it's heartbreaking. So as somebody who has been involved in training for many years, I find that, coming up to the end of a training program, my senior trainee now says, I'm reevaluating my life and my choices that I've made. And I just think that's, 7, 8, 9 even years of training for someone to now say, I'm going to leave medicine. And I think that is really profound. And a lot of the reasons it is mental health. It is, stress, anxiety, depression. And when I've sort of looked at this further, I mean, obviously COVID hasn't helped the situation. And if you look at just COVID itself now, we had a background rate of maybe around 5%, COVID, 21% of depression, and understandably, because the pressures that the NHS has had to face, and each and every member of staff has had to face, whether directly involved in the COVID workforce, as in what I say is that I'm an obstetrician gynecologist, so I have not been the front line, but the back pressures of that kind of environment has been just profound. And when I put my medical educator hat on, I've never seen this much mental health issues in my medical students. Again, statistics, around 25% of medical students in the world will have some sort of mental health problems. And I just find that why is it becoming such a big problem? I was a medical student, I was a trainee, we didn't talk about it. That doesn't mean we didn't have it. And I think one of the things that I've learned with time is that, we do need to practice what we preach. So if we're telling our patients this is important, then it is important for us. And Raghu mentioned that one of my sort of passions is in the leadership role that I have is to actually have those conversations. but to create that environment of psychological safety. And I'm sure in the discussions we will talk a little bit about why these issues have come to light now. Is the NHS such a bad place to work that everyone's deciding that, I'm going to have a mental health problem? It's not. I think there's lots of pressures, but also it's about individuals and who we are as people who join the healthcare workforce. And just to give you some examples, we are perfectionists. And we also don't always take criticism very well. And we tend to work in an environment that's highly pressured, but also sometimes very incivil. And we know incivility kills, but it kills not just patients, it kills individuals. And from experience, and I will promise that I will end on this, is that, we need to break the taboo. And I think Raghu mentioned this, and I think we need to break it more within the healthcare workforce. So when I've spoken to colleagues in the coaching role that I do, or I'm speaking to medical students in my head of year role, I say, well, why haven't you come forward with this before? What is the issues? And they'll say things like, well, it'll damage my career. I'm not going to talk about this. And if you add the BAME, so the sort of the ethnicity background onto it, and we're going to talk about culture, I'm sure, at time, it just compounds the whole factor, because culturally, we just don't talk about these things. Culturally, it's not something. I'm supposed to be the doctor. I'm supposed to be the one that is supposed to help people. What do you mean I need help? But there's a lot of stigma around my career progression, what I'm going to be perceived as, am I seen as a weak person because I have a mental health issue? Will people treat me differently? And then there's this whole issue around how our regulators will see us. So a lot of my senior trainees are really scared to admit mental health issues or seek help because it's going to go on my record. So even when they come and have a conversation with me, they'll be like, this is confidential. You're not going to put it down anywhere. And I'm like, no, I won't. But there's this fear that the GMC announced, so the General Medical Council, for those who are not aware of it, they'll be watching me. They've got an eye on me because I have this issue. And in some way, it feels to me that people feel that if they have a mental health issue, they're like broken goods, and they're not. It is just like, in some ways, having another illness that we talk about, we seek help, but for some reason, as health professionals, we're not good at it. And I'd like to have that conversation. I'd like this conversation to occur across the world, because I'm sure that in India, health professionals have the same problems and the same issues. Thank you.
Thank you very much, Angie, for that very connected conversation around that, in terms of how it actually touches the kind of way how professionals actually see that, and the kind of silence around their own mental health and well-being. And I think the challenge is there in terms of how we open up that, and so that people have the boldness and the right environment to actually have those conversations for their own well-being and for the well-being of the people that they actually serve as well. Thank you very much indeed. That we'll come back to that in a minute. Now, let me go to Mr. Paul Illingwoth. And Paul, over to you about your story, please.
Thank you. My cursor wasn't going where it should have been in my life. Okay, so I'm going to take a slightly different stance here. Yes, I started my professional career as what was then called a general nurse, adult nursing, it's now called in the UK, looking after people's physical health. That was, I know I only looked 20 odd, but it was quite a few years ago that I actually started my career. And when I started my general nursing, we looked after physical ailments. We were often heard to say, and other people said, oh, go and see the heart attack in bed 6, or go and see the fractured neck of femur in bed 7. We didn't talk about patients, we talked about their conditions. And we had very little teaching around mental health. I was lucky enough to have a 12-week placement as part of my general nursing on an acute admission ward in psychiatry. And I was on that ward with a colleague another student doing a general nurse training. And there was a lady on that ward who'd been a patient for several weeks, and she'd had various treatments to improve her depression, and it hadn't worked. And they were just about to consider giving her electroconvulsive therapy. And Elaine and I, the other student, were very uncomfortable because we felt there was something else going on. And so as relatively junior nurses, we spoke up, which you didn't often in those days. And we questioned whether they'd actually got the diagnosis right. And luckily enough, we had a very open multi-professional team. We didn't call it that then, but that's what it was. And the consultant said, "What do you mean?" And we said, "We think she's got an underactive thyroid. Has she been tested?" So the consultant looked at the junior doctors and they went, "Oh, no." So they tested and she had an underactive thyroid, treated her with thyroxine. She was discharged quite quickly and obviously didn't need ECT. So that's one example. Secondly, when I went to do my mental health, I would be about a year, just over a year into doing that training, and my father died. And because I was already a nurse, I went over. My family expected me to deal with everything. I did deal with everything. I put my professional head on and dealt with it. And 6 years later, it hit me like a thunderbolt. I reacted to the fact that I'd actually not grieved. I became quite severely depressed and did have suicidal thoughts at the time. Thankfully, I had people around me that supported me, and I got help, and I came through it. Qualified as a mental health nurse, and I'm going to mention an incident where I was charged on a ward with a male patient admitted, and with a diagnosis of potential atypical schizophrenia. And he was having intermittent outbursts of aggression. And again, I was lucky enough, myself and the other charge nurse and the two staff nurses that I had on board, we'd all qualified as general nurses before we came into mental health. And we were asking, let's just do some tests on this person to find, because this is not right. It's not a typical presentation. Again, further tests were found that he had a tumor near to his pituitary gland, which was affecting the impact of his hormones and affecting his aggressive behavior. Consequently, he had an operation, had it removed, and thankfully successfully survived. So I think that incidents there where we've got to take into account, obviously, if we're not careful, we miss those things. Now, why I mentioned that I'd had depression is I'm absolutely have no problem about talking about the fact I've had depression. But I've also had cancer. So in 2005, I had bowel cancer. Now, when I did my general nursing, my first ward I worked on was a surgical ward that dealt with people predominantly who got cancer, predominantly bowel cancer. And at the time that I was doing nursing, the type of cancer that I had, if you were lucky, you lived 6, 12 months. Well, I was diagnosed in 2005. So I'm bucking the trend in that respect. And excuse me, and those people who know me well, they'll say, what's the word I want to use? I don't give in to things very easily. I'm a very determined person. I won't let things get me down, and I certainly wouldn't let cancer beat me. So luckily, it was diagnosed early. I was treated. And in 2005, I was living and working in London, in the south of England. My family and friends were predominantly in the north of England, many miles away. Hardly saw them. I didn't see many of my colleagues and friends, although I did see some of them. When I went into hospital for the chemotherapy, there was good camaraderie with the other patients that were also having chemo, and there was black humour going on, and it helped us get through that. I had face-to-face meetings with the oncologist, the surgeons, the multidisciplinary team, and the GP, and I got through it, and I got through it well. And then in 2020, in an attempt to avoid being hit by COVID, I then was diagnosed with mouth and neck cancer. So it got me out of all the work I had to do in work. That was one positive. But as you can imagine, having surgery followed by chemo and radiotherapy, it's quite a challenge. The best part for me was actually going and having the radiotherapy 5 days a week for 6 weeks. And you might say, why? Well, the reason was it was the only time I actually got out, because the rest of the time I was stuck at home. I was isolated. My wife's a nurse, so I was almost isolating from her as well because of the high risk that I was at of getting COVID. I spent most of my day in one room. I slept in that room. I ate in that room. And then when I came back to work for 12 months, working at home, I was working in that room as well. And surprise, surprise, I got depressed. I was isolated. Unlike in 2005, when I went to hospital, when I was going to hospital in 2020, you didn't have the camaraderie with the other patients because we were all separated. Our appointments were at different time. We were wearing masks. We didn't talk to each other. So that humor that I had the first time wasn't there. And as I say, the isolation was terrible. And again, the other thing I suppose is actually when I went to see the oncologist and the surgeon, there was a gap there was a barrier there because they were wearing masks, I was wearing masks. Similarly, when I saw the multidisciplinary team as well. And also GP, I was having phone conversations with the GP rather than face-to-face contact. So although I've got a physical illness, it wasn't the physical illness that was really causing my depression. It was the social isolation that I was actually going through at the time. And although I started on antidepressants, the thing that actually picked up my mood more than anything was coming back into work for 1 day or 2 days a week and actually seeing people and talking to them. And for me, that almost got me, well, helped me get through it. I mean, it wasn't going to get me down. I wouldn't let it. That's not me. I won't do that. And I think because I've had this experience, because I've had my health problems as well as my working practices, I've stood up and shouted out about mental health all my life because I think we should talk about it. I will do the same for cancer because there's as much stigma about having cancer as there is of having mental illness. And I think sometimes organisations, the NHS, Macmillan nurses or other, can actually perpetuate that stigma because we almost see people who've got cancer or mental health, they need overprotecting. We don't always. Some do, some need that, but not everybody. I'm going to stop there, otherwise I'll be talking for another hour.
Thank you very much, Paul, for those personal stories in terms of the early days of the training and also in terms of your personal experiences with cancer and the kind of isolation and mental health challenges that you experienced. Very touching story. I'm sure there are many people who have actually, especially during the pandemic phase, when you actually went into the second phase of the treatment. And thank you very much for sharing those. And I'm going to come back to those questions in a minute. Our third panel pitch is by Dr. Anjali Viswanath. So over to you, Dr. Anjali.
Thank you, sir. I would like to start with our Indian scenario. Like the latest study done by ICMR in 2016 shows that 1 in 7 person in India suffer from mental health disorder of different severity. It may not be a major mental illness, but still, as sir told earlier, mental health is something like mental health is not just mere the absence of disease, it's about well-being. So we know the magnitude is too high, but still the treatment gap is almost 83% as per a recent study. So that explains how huge the scenario is, how huge the difference in treatment taking behavior is. So coming back to the stigma, as Dr. Angie was talking, it is very much in our country, like in a country like India, people consider some illness better than other. Like if you are diagnosed with a diabetes or a hypertension, people talk about it, people ask for help, people ask for lifestyle modifications. But if someone is diagnosed or someone is having any mental health issue, they never come out of it. They will not communicate about it. It's sometimes, in my personal experience, I find some people taking it as a death sentence. oh, I am diagnosed with a depression. Like it's like something very serious, and something definitely it's serious, but it's something which is not curable. It is something which makes their personality bad, or which makes their personal behavior bad. So there are some people who take it that way, and there are some other group of people who take it in a different way. They will not give a consideration for that. They will think that it's something which can be changed over time. They can have a control over thoughts, and they will try to get it sorted by themselves. So these are the two groups of people which we encounter daily in our OPD services and in our general care settings. So people does not understand how mental health is connected to physical health. People consider it as two different compartments. Mental health is here and physical health is here, and there is no connection between the two. That is the general understanding of the people. And talking about the statistic again, 14% of the global burden is due to mental health disorders, various neuropsychiatric disorders. And to add on that, people with mental health disorder die 2 decades earlier than people without mental health disorder. So that means how much implication mental health is having on our physical health. So, and moreover, there are many conditions in which people present with mental health issues. For example, certain infections like HIV, Lyme's disease, certain endocrine disorders like thyroid disorders, certain metabolic issues, certain vitamin deficiencies, and generally certain cancers, neoplastic conditions like pancreatic cancers present with depression. And also, as Sir told earlier, the comorbid mental health issues can worsen a physical condition. Diabetes, which is a very commonly diagnosed condition, if a person with diabetes is having a comorbid depression, his illness is going to get affected badly. He may not go for frequent follow-up. He may not check his blood sugar. He may not take properly medication, and that is going to affect his physical illness in a bit. So there is a close connection with it. Mental health and physical health. Mental health is an integral part of physical health. People do not understand that. And moreover, whenever someone is diagnosed with a mental health issue, they're not coming forward with full problems. They are shy to come forward and tell that I have this much issues, I have this problem. They'll think that it is their problem. It is because of their thought process. It's because of their personality they are having difficulty. So what I wanted to highlight is that in India, the stigma and lack of awareness is very much more than in the developed countries, and we are starting a lot of mental health awareness programs, and definitely it has a positive effect on the outcome. And awareness and health literacy both are like an opposite side of a coin, and both should be taken care properly for the patient to understand the importance of mental health, to lead a happy life, happy in the sense productive life. As Sir told, well-being, we should be able to do our work, we should be able to cope up with the normal stresses, we should be able to be productive and give a full to our life. So definitely there is a connection, and that connection should be perceived by the population.
Many thanks, Dr. Anjali, for making the connection of physical health and mental health. I think it's not a conversation that normally people actually have. You either talk about physical health, you talk about mental health. Many thanks for actually connecting that link. I'm sure there are a few questions in relation to that, how we encourage that conversation. I'll come back to you in a minute about that. Last but least, Dr. Sam Manickam, over to you, sir.
Thanks, Raghu, for the invitation, and I'm glad to be part of this panel. Listening to the previous speakers, I was wondering where I need to start. When I got this invitation, I was thinking about the 72nd World Health Day's theme, Our Planet, Our Health. And Raghu was asking us to talk about no health without mental health. And in that connection, I was actually looking to the Sustainable Developmental Goals, which UN had set, which has to be achieved by the year 2030. And the goal 3, which talks about ensure healthy lives and promote well-being for all at all ages, is a great challenge. And we know that we have already crossed almost 1/3 mark, and the pandemic had made much more complicated in reaching or achieving this goal of UN Sustainable Development Goal. We also had previously different goals, health for all, elderly, all those things we have passed through. So we have been passing through different goals, but I don't know how much we are able to achieve the goals that we are setting. But based on what we have been discussing, I was also thinking about my own experience with the health and mental health. That was a time when I was working in a medical college in Chennai, where I had a lot of requests from the other departments like the medicine, emergency medicine, and various other departments where they were asking the help of psychologists and not, they were not referring to psychiatry, and they wanted the psychologist to come in. I don't know whether it's a relationship I had with those heads, or whether it was the perceived need by the concerned physicians about the mental health aspects of it. Maybe they were concerned about the well-being, not the medication part of it, which they would have felt at the time, or the need for listening. You know, the patients who had diagnosis cancer, they don't know whom to talk to, and the concerned treating physician didn't have the time to listen to them, but they wanted somebody to listen to them so that they can take care of that aspect of it. That made me think in terms of what Dr. Anjali was talking about, the mind-body divide. I was wondering, whether we have been trained to look at only the body and the mind. And when we talk about the cultural aspects of understanding a person, I'm not talking about the illness, I'm talking about the person, or, then you have not just the body and the mind, but there is something more, and which I think the Western, I don't want to use the word Western because we don't know where is East and where is West, but in many universities in the universities in US or in Europe, they've started including the spirituality aspect of it, which is based on a different, I don't know how you can have a theoretical foundation for that. So if you look at the Indian concepts of person, you find the panchakoshas, where you have the physical, the psychophysical, the psychological, and the cognitive, as well as the spiritual dimension coming. So I think we need to relook at the person that we are dealing with, rather than just seeing as whether it's a body or a mind problem. And that might help which Angie was talking about, the educators, health educators, or the physicians in training, or the nurses in training, or all those who are caring for the people, will be able to probably relook at things in a different way. I had the opportunity to be at a couple of medical colleges where I had the opportunity to train them, both from just the behavioral aspects of it, as well as the psychiatry aspects of it. And I could find when they are asked to interact with a patient, we could see what is sort of coming up within them. So as health educators, or as trainers, we need to identify people who need to attend to their own issues. So if we can do that, they might be able to be good care providers in the long run. So I think that's where I would like to stop now, because as I'm listening to more health providers who have been undergoing through different kinds of stress, not only what Paul had mentioned, but the global scenario of the conflicts, which is causing a lot of problems for people living in different parts of the country, including India, because it's not our planet. When you talk about our planet, it's what is affected as one part of the globe is affecting the other areas. And I think we need to be looking into that also. So I think with this, I would probably leave the forum for more discussion, and I would like to respond to both questions that comes up here. Thank you.
Thank you very much, Dr. Manickam, I think, for that insightfulness in relation to the body and mind, and how actually trying to have the understanding of physical illness and mental health issues, and also the kind of challenge the world faces in relation to the the development goals, number 3, SDG number 3, and whether we're in actually achieving that global health and wellness in about 8 years' time. I'm sure they will be moving that the time frame later on into other stuff, because I think there are more important things to the global challenges that we actually face, both in terms of physical health and mental health. So many thanks. So I think that brings together a kind of a nice, rich, valid, contemporary narrative in relation to professional dimensions, personal dimensions, the physical health and mental health issues, and also in terms of the global challenges that we actually face, both in terms of physical health and mental health. So my first question is actually in relation to the Professor Angie Doshani talked about in terms of medical professionals and why people are very reluctant to actually talk about their own mental health and well-being issues. So the broader question to the full panel is, how can we encourage our health professionals, our medical professionals, to be open about the mental health condition? And what are the kind of ways in which that could be, that conversation, that fearless conversation could be encouraged? And also there is an educational angle as well. How is it that they are, that they could be sort of trained better to understand their own well-being and also communicate that for the betterment for themselves and of others? So over to the panel. Yeah, I think I'll direct that to Angie first.
Thanks, Raghu. I think we've had a live demo of this with Paul sharing his story. And I think the more we share our stories, the better we get at breaking taboos. So people, I'll talk about trainees and medical students and the whole concept of role models, which is a really powerful concept. So, I look at someone, I think, oh yeah, when I grow up, I'm going to be like this person. And if this person comes across as someone who is open, honest, and willing to share their feelings, but not afraid to talk about the not so rosy side of my life, then, it makes me feel that it's okay to talk about it. And so I think this is where leadership is really important. It's about having the courage to talk about it. So I'm really, really grateful, Paul, for you to share the story, because it would have been very easy to talk about, and it's personal, obviously, to talk about the cancers and to talk about all of that. But to talk about the mental health within that is a whole different dimension that we don't do. So people, and I think Anjali mentions this, that you talk about, your diabetes and your hypertension, but the impact all of these chronic conditions have on your mental well-being is something that we never talk about. So I think role modeling is really important. And the other thing I think is really important is about having this, what I have always talked about is a environment of psychological safety. So where I can say things without being judged, where I can be who I am without someone saying, oh, you know what, this is what Angie said, and this is what, oh, do you really think, do we think she should be part of this team? And I think that therein lies the biggest reason now of burnout and stress within our workforce. I strongly believe that, because I think, yes, patients have changed, the working environment has changed, but the core of who we are as doctors may have changed. I'd be interesting to hear what the panel and the audience think about this, is because in the NHS, we are very fortunate, yet have challenges, because we have 4 generations of workforce who have very different ideas about work ethics, values, working life, work-life balance, and I think that sort of conflict doesn't help. But it's about having that open culture. And I think, when Sam talks about it, he talks about that being open, but appreciating that my trainee is not going to be like me. One last thing I want to just pick up is what Anjali said about the sort of relationship between physical and mental health. And just to give you an example of what I see in my practice with medical students, we're getting better with our patients, but with medical students, it's taken me a little while to figure out how this presents. And a lot of the times they will not come and tell me, although I will be honest, in the years that I've been doing education, things have got better. Students are now voluntarily coming forward and saying, I'm not right, I need help, which is great. But the way I normally sometimes pick them up is attendance issues. So when they're not pitching up for placement, so 3 days, 4 days, you're back in my office. Let's talk about this. And it's about having that talk. It's like saying, what's going on? Tell me what is happening here. Or there's vague headaches. So I have a migraine. I've got too many migraines on my books here. And the other is the vague abdominal pain and this recurrent gastrointestinal symptoms. I mean, I'm becoming a pro in GI problems now. And it's about how you sort of, wade through all of those symptoms to actually get to the bottom. And like taking a history and a mental health history, and I'm surrounded by people who have much more expertise than I have in mental health. But when I was a trainee, God, it was like 10-second session, literally on, are you okay? And that was the whole summation of mental health. At our medical school, we do a lot more now in asking questions about mental health. But it's how do you translate that question to yourself? And therein lies the biggest challenge.
Thank you, Angie. Paul, I think you've raised your hand. Obviously, I will pass on to you.
Yeah, thanks, Raghu. There's several things I want to respond on there, and some that were in the talk. So I think, Angie, you talked about it costing us 150 million. I think that's a way underestimate, to be honest, because there's a lot of cases don't go reported or people hide it. And there's also the knock-on effect of the impact it has on families and friends and everybody else. So, we could probably triple that, I guess, as a rough estimate. You also talked about, it's become a big problem. I don't know whether it has become a big problem. Maybe we're just reporting it more now. So we have perhaps improved a bit, but we're perhaps not quite where we should be yet. Coping with that and dealing with that. Thank you for saying that, it's good that I've come out and spoke about it, but I don't care. I've had mental illness, I've had cancer, I've had bronchitis. I talk about that. Why can't I talk about it? It's another illness, that's all it is. I'm happy to talk about it. If you want me to come and talk to your medical students, yeah, I'll do it. It doesn't bother me in the slightest. And I think, the role model things, yeah, absolutely. I think one of the things that perhaps helped in the West is celebrities coming out and saying that they've got mental illness. I think for some of them, it might be trendy. I'm not sure what they mean by mental illness, but the fact that they're actually talking about it a bit more, and that we've had some famous people, there's been through history, famous people with mental illness, not always told and talked about, but there's more of that happening now. That's all helping. It helps in the West. It may not help in other areas of the world that haven't got the same communication about there. There isn't as much of the electronic connections and the celebrity status. So therefore, it's about having local people to be that role model and to stand up, people like myself and others to say, yeah, I've been ill. I don't have immunity because I'm a health professional. There's nothing that protects us because we're health professionals. The culture, the celebrity culture can help. The faith that we have, the communities we live in, it can help. It can hinter. And role models, I can think back to some good role models that I've used. A handful of good role models, but I can think back to a lot of very poor role models, and they've had as much a bigger impact on me of how I do things going forward. And I remember working with someone who clearly had mental health problems, and it causes all problems, but no one would talk about it. So, everybody knows, well, I think everybody knows Raghu at work, I've got health problems. I don't care. I'll speak up and talk about it to anybody. Anytime, anywhere. That's it. I'll shut up again now.
No, thank you, Paul. I think that's great in relation to the kind of the role models and how it is important for us to actually talk about these things is very crucial. I don't know whether I should disclose this myself as well. I think I can also talk openly about the cancer argument here because I never said this in public. I can tell you this, I was recently diagnosed of prostate cancer about a couple of months ago. And I think it is something that was very unknown to me over the last time. I never knew that until the health service actually discovered that I have a prostate. And I think it is actually quite distressing at that moment in time. But I think it is important that for us to understand what it is actually. It is yes, it is highly prevalent. 1 in 8 men in the UK actually have prostate cancer, and I think men don't actually look at our own. We don't understand them, so we don't actually go and have a checkup after the age of 50 and whatever. So it is important that we actually understand these issues and not necessarily think that this is a taboo to actually talk about cancer. And there are adequate, well-tested treatments that actually readily available for you that might be actually help you to actually get to the cancer element and also to create better health and better mental health in that time, and also to support your families as well. So it's important that we try and talk about that in the best possible way so that it helps us to understand our own issues and also to support others and also to create that mental health and well-being. So maybe this I have never done this before in terms of talking about my own health, in on a live performance here. Go on, Paul.
Thanks for telling us that. I mean, Raghu told me that last week, so I didn't know about that. It's great that you've done that. Well done. I think I forgot what I was going to say now. Oh yeah, I think what we need to do is have more of it, and it's great that you've done that. And the fact you're doing that and others do that, it does break down that stigma, but it also has a cathartic effect on you by doing it. It actually takes some of the pressure out of you. And what I guess you'll find is what I've found on both occasions when I've told people I've had cancer or I've had depression, the number of people that come and say to me, oh, yes, I've had cancer or I've had depression. And it almost gives them permission to do the same, really. So it is that perpetuation, role modeling and reducing the stigma. So well done.
Thank you. Thank you. Dr. Anjali, same question in relation to the kind of professional education in the Indian context. I'm sure you should be able to tell us more about it.
Yes, definitely professional education. Many people are suffering from many mental health issues, but they do not come forward. They do not come forward and talk. As Dr. Angie told, it's very easy for them to tell about their headache. They might tell stomach ache, abdominal discomfort, but they never tell their professors or teachers or colleagues about their mental health issues or the stress they're facing. So there is an entity called medically unexplained somatic symptoms. 1/3 of the medically unexplained somatic symptoms are due to such psychological problem. Common symptoms are fatigue, dizziness, pains, unexplained pains. So many of such cases improve with a CBT, cognitive behavior therapy, or just adding on an antidepressant. They might improve. So it is very easy for people to talk about their physical health condition, but they do not talk about our mental health issue. So recently there has been talking about mental health condition in the professionals, especially in the medical professional. Suicide among doctors, suicide among mental health students, medical students have been increasing a lot. And when you look retrospectively, they were not evaluated. None of the friends knew about their issues in most of the cases. When we look back retrospectively, we find that there were behavior changes in them. They were stressed, they were not interacting with people. They had this kind of multiple somatic symptoms, headache, migraines, stomach pain, leg pain, and pins and needle sensations. I'm just talking about one case which I encountered recently. So when we retrospectively looked into their history, they were having many of these type of somatic symptoms which were not given much importance. When they told about headache, okay, just have a paracetamol or Dolo, it will go away. But when it became a suicide, when we lost one life only, we were able to look back to those symptoms and connect it with the mental health issue. So definitely in suicide among doctors and suicide among mental health professionals are increasing, and definitely work stress, burnouts, everything contribute to that, and they do not find anyone to talk to. like when a mental health professional or a health professional gets some mental health issue, they feel that they might be considered weak, as Dr. Angie told earlier. Like if I tell about my mental health issue, if I tell that I'm not okay, will I be considered as a good doctor? Will I be considered as a good health professional? That thoughts are like that thoughts are haunting them. So it is always better, like if we show the models, like Dr. Paul told about celebrities speaking about their mental health issues. Recently, we had, I don't know whether you know about Deepika Padukone, Bollywood star. Okay, she had talked about her depression. She had participated in a lot of campaigns. She's talking about in social medias, and definitely there is a sudden rise in people talking about depression in social media. After her coming forward with her symptoms, there are many people coming forward and talking about it. So definitely we need models. We need models among the professionals itself. Like what you had done, Dr. Raghu and Dr. Paul had done now is a great thing. Like it's a motivation for many people. Like they should know that there are people like you, or people, there are many people suffering from such conditions, and it can be cured, it can be treated. You can get support if you talk about it, rather than getting judged by people. As Dr. Angie told, like if I tell like this, I might be judged. Will they judge me? Why she's talking like that? Why she's like that? That thought should be controlled. That short thought can be controlled only by models coming, models in the sense, it can be mental health professionals, it can be professionals, it can be celebrities coming forward and talking about their health conditions, so that more and more people talk about it, and we can extend help to more and more people. That's it.
Thank you very much, Dr. Anjali. Over to you, Dr. Manickam, in relation to how, especially within the psychology crowd that you're very much familiar with, and you've been involved in the training of many psychologists in India. And what about the kind of the burnout, mental health issues among the psychology professionals?
I think I would start with the question which Angie brought up about the psychological safety. I was reminded of an article which I think was published in the 70s by Professor Neki, who was a psychiatrist, who talked about the confidentiality aspect of it. He was addressing the psychiatrists, mainly psychiatrists and the psychiatrist trainees. So we say that things have to be in confident. We say that it will be confidential, but you can hear the things in the corridors. It was quite disturbed a couple of days before. One of the clients that I'm seeing, who is a doctor, she said that she was in a restaurant, and in the next table, she could hear somebody talking about a patient, about the medication, about the illness, and how he is not being looked after, or how he is not being adhering to the treatment. It was not in a good taste for her, and it actually disturbed her, and she had to call me. So I think this is very important. We say that we keep it confidential, but in practice, I think we have to reevaluate our own concept of confidentiality and things like that. Second thing is a couple of experiments that I did with the medical students, being the student counselor in medical colleges. One of the things which tried out a couple of decades ago was, as soon as the students come in, we conduct groups for them in small groups, allowing them to talk about, as Paul was talking about the stress they have of being away from home, being in a hostel, stress of studies, the academic pressure, getting exposed to cadavers, some people who have problems with blood, seeing blood, and all these issues could come up. And we could, in the group, we used to give them an open invitation to contact us in case of any need that they have. And fortunately, that college had another system of having one person in charge of 10 students. So they have more intimate interaction with the faculty member to share with them, again, in confidence. So if there is a need, they could refer them to the appropriate person. That had worked. And another instance when we did this, there were sort of some resistance from other people saying that one person should not be conducting the session for the students. But I was insisting that to keep the confidentiality, that is very important. So if the person is coming and talking to me for the first time, it is important that it has been continued and taken over rather than having people shifting. You know, a medical student comes and meets me one day, and the next session, if I'm not there, of course, the trust, the relation, the rapport that is built, everything will be lost. So different ways of things according to the context can be evolved so that we can identify people who are just in the early stage itself. Some of them may come during their internship days or PG days and tell that, okay, this is something which I was experiencing through all this time, but I didn't want to tell you. But though you had discussed about this issue at that time, I didn't want to open up at that time, but I would like to talk to you. And I wouldn't say that they have to come to me. I would say that you need to take help. From whom you take is your choice, and I will give you different options for them. Whether you want in the college or outside the college or at different places. Now the pandemic has brought in a great opportunity because two, three things. One thing is which Anjali was talking about, that the gap, the treatment gap of 83%. So we have professionals who can provide the listening services, more than 1 lakh in the country, in India, but I don't think we are making use of them appropriately. Listening, providing the psychological first aid or initial psychosocial support doesn't need much of an intense psychotherapeutic training, though we talk about psychotherapy training being provided in the primary health center now these days. But for this kind of a support can be given, and we can make use of the large number of people who are available with supervision. And second thing is the telemedicine that has come up, or telepractice that has come up. And our finance minister has brought in a huge change in our country of saying the budget for developing the telepractice. But I would say that we need more regulation that might help, or that has helped health providers, frontline workers during COVID times, accessing help. And that avoids a stigma too. In fact, I was discussing with a service provider, a psychiatrist from one of the metropolitan cities. So he was saying that I don't want to go back to in-person consultation. No, I'm very comfortable with teleconsultation, and I can help people from my own city who are living in any part of the world. So that is one of the things I think we need to probably make use of in providing the help to a large number of people, especially service providers, so that the issues can be brought up. In different groups, we were discussing this, especially because we want doctors in our country. We don't want them to get burned out. Talking about psychologists, yes, Raghu wanted me to talk about psychologists. We are providing the support fund for them too, but this is one of the concerns that we were discussing in this small groups forum, because we experience this when we are responding to the disasters. When we go to the relief camps, the doctors come to us running, saying that, see, we are sick of seeing this people with different kinds of injuries, etc., etc. We want to talk to you. They want someone to talk to. So they keep running, and we were able to provide that. So that has given us the kind of realizing the need to provide that at a larger level. During the COVID times, there were many people who were having difficulty in terms of how to use PPE kit and struggling with a lot of things, especially the women in different phases had different challenges. So a lot of stress they had undergone through, which they had been able to talk to when there was some kind of a support person and get relieved of their stress. I'm not saying that they were able to get over the issues, which all those things which has happened in isolation, etc., etc. But there were a lot of there's a lot of need, and I think we need to bring up people who can provide people service to the people who are in need. Yeah.
Thank you, Sam. We've got Paul and Dr. Angie have put their hand up. Paul, over to you.
Thanks. A few things there. I mean, I think talking's cheaper than giving people medication, and if we can get people to talk more, it allows them to actually talk about it, offload it, it breaks down the barriers, the stigmas. So we've got to do something to try and reduce that stigma and get people to talk. And, you know, if you look at the WHO action plan, it talks about looking at providing more medical care, hospital care, and things like that. Actually, you know, many countries in the world can't do that. They haven't got the money, or they, you know, there's one hospital and people have got to travel miles to get to that hospital. You know, why don't we do something like the friendship bench, which is, you know, developed and things like that, where you can actually just sit and talk to people? That's cheaper, that helps. But we do have to work on getting that stigma down for people to do it. I think the point about your telehealth is really important. I think it's a really useful thing. I mean, it's actually been used in Australia for years, so you know, it's not new. But I think although it has some benefits, we've also got to think about one important risk. If the person who is talking to us about their mental health problems is in their home situation, and the cause of that mental health problem may be their partner or somebody in the family who's abused them, attacked them, they're not going to talk about it. So we've got to think about that. And the other things about confidentiality, I think we do sometimes get, as professionals, hung up with that. Yes, we've got to be confidential from a professional perspective. But I had a conversation with someone who does telehealth a couple of years ago, and they'd had an incident where they were actually working with this young woman. She was in early 20s and talking to her about her health problems. And she'd had 2 or 3 sessions with her. And then she realized the woman she was talking wasn't on her own when she was having this conversation. And she said, "Are you with someone now?" And she said, "Yeah, I've got 3 of my friends with me." And so the person said, well, we need to stop this conversation then, because, you know, we need to talk privately. And she said, "But why? All my friends know what the problem is. All you're doing is actually," and she's quite a clever, intelligent person, this, she said, "you know, all my friends know about it, so why should I hide the fact that I'm actually in counselling with you? And they're listening to what you're saying, and they're going to use that to help themselves and help me anyway." So, and that was quite a dilemma for her, because obviously professionally you don't open up in front of other people, but, you know, this particular person, yeah, why not?
Yeah, I think talking is the best therapy that we have. I think according to statistics, in the last quarter of last year, there were about 70 million antidepressant prescriptions given out by the NHS in the UK. Just in the last quarter of 2021, 70 million antidepressant prescriptions. And I think, you know, conversations is cheap if there isn't, it doesn't have to pay for anything. And I think that, you know, you get immediate reaction, you get immediate reflection, a lot of other things that actually happens as well. So we will, you know, I think it's important that we connect and discuss and talk about those things. Dr. Angie, I think you raised your hand.
Thanks, Raghu. Just picking up from a couple of things Paul and Sam said. I mean, I think we miss a trick here, because being Asian, what is the best thing that we do? We can talk, right? That is our special skill, is what I call it. Unless, of course, you're my husband who doesn't talk. And I'm sure most people will agree, if they have husbands, that they don't talk when it suits them. But otherwise, I think talking, if you think about it, and I think we raised this around faith and, you know, people, role models, and whatever have you, I think it's about how you broach the subject. And I think we talk about everything under the sun, and it's about the kind of importance you put on the subject, or whether you can laugh it off. And I think if you can laugh it off and say, yes, I have it, and yes, I've done this, and yes, we're talking about it, I think, you know, it's cathartic, it helps you, but it also helps the person listening, rather than this is a grave conversation about my mental health. You know, so it's the attitude you have towards talking, and nobody can beat us in talking. Nobody can beat most Asians in talking, she says. So, you know, we miss a trick if we're not harnessing our talking therapies, is what I feel. One of the points that I wanted...
Yeah, go on, sorry.
One of the points I wanted to pick up from what Sam was saying is that I think so far where mental health conversations have happened, they've been more reactive rather than proactive. And I think that's where we need to change the meter. Our sort of needle on this meter is to have this more proactive conversations. So I give you examples of in healthcare where I know my students are going to have, issues and concerns. So I look after third years. Third year is the move from preclinical to clinical. That's a really stressful time in their lives. You know, it's like, I'm really going to be a doctor. I'm really actually going to touch a patient, although they do touch patients right from year one. But I know that's when their mental health is going, because they are now in a proper working environment. They're not in a classroom environment. My trainees moving in from junior reg to senior reg, moving from registrar to consultant, consultants taking leadership positions. Those are all stressful times of our careers. But it's also about personal stresses that we never talk about. So we're very focused, and we are one person. We have a life outside work, and we never make allowances for that. You know, yeah, if you have an illness, we'll make allowances. If you have cancer, it's expected. You have a miscarriage, it's expected. You have a child and you go on maternity, it's expected. But I don't have to have all of those to have something else going on in my life that is affecting my mental well-being, isn't it? And I think it's about being able to understand the impact this has on my working performance, but also the support that I will need. And you know, it's really interesting. You talked about the prescriptions of antidepressants. Now, Anjali might, because Anjali would probably correct me if I'm wrong in this, but I find that especially patients from ethnic minority backgrounds, and when I talk about South Asians, are so reluctant to go on to a medication for their mental health. You know, they will just, that would be the last thing on planet Earth that they'd want to take for their mental health, because then in some ways in their heads, it consolidates that I have a problem. And as long as I'm not on a medication for something, I don't really have a problem. It's like diabetes, you know, diet control is borderline. It's fine, it's okay, I can manage it. I don't really have diabetes. But when I take medicine for diabetes, then I'm diabetic. And that is the difference. And Sam, I just wanted to question this from an Indian practice perspective, because I understand the psychologists in the UK, again, in the proactive theme of conversation, as part of their work, they have regular, what they call as debrief sessions. So as part of their work environment, they have to demonstrate that they've themselves had a debrief session, which I think is really useful. We're getting better at it, but in the NHS, we do debriefs when an event occurs, and usually a serious untoward event, right? And where there's expectation that we will have to debrief now. But we just don't debrief when we've had a really busy day, or we don't debrief when we've had a good day. And there are things like Schwartz rounds that are now coming up, which help to talk about not the actual nitty-gritty of what happened, but more about emotions and feelings. And I just wondered whether in the Indian context, there was something like that for the medical workforce, or for psychologists like yourself, where, you know, once in a couple of months, I have to go to a session where I have to talk about my feelings. And sometimes, you know, when you have to do things, it may just get you into the mindset of doing it.
I think I'll respond. Yeah. Can I respond to that immediately, or do you want Paul to go first? Or you want Paul to go first? Or okay, yeah. Thanks, Angie, for that. Ideally, what you said is good, and we advocate that. But in practice, we have several issues which prevents people from, again, that kind of a supervision. So when we talk about, you know, in the West, when I talk about West, in US or in UK, when you're in the training, it's a supervised training where there is very kind of, you know, systems, two levels. One thing is, you know, as you have mentioned, you know, the therapist has to undergo therapy for oneself so that I address my own issues, which I was also not aware of it when I was a trainee. I thought that, you know, I know everything. But then I went for a training where they made me to work on my own issues, where I realized, I need to work on my issues. And that made a great difference for me, which I share with my trainees also, or other people. So there is no harm in working yourself if you want to be a better therapist. But when I say this with my the psychology colleagues here, some of them realize it, some of them feel that, oh, why I need to go for a therapy? I am a therapist myself. So that attitude is very much there. So that's where when I mentioned that the more than 100,000 psychologists who are available there, make use of them with supervision. I added the word with supervision because they have to be under supervision, so that, as we say, even if you don't do any good, please don't do no harm. So that's a message which I give you. I don't want you to do something for the person, but do no harm. So you need to know what can be harmful for another person too. Yeah, and since I mean, I wish that you, the medical teachers were like you, where they pick up on things like the attendance, the excuses which they give for delaying various things, because those are the indicators of identifying people who have stress. Some of them may be sort of tricking you, as my grandson says, "You are tricking me," but this is not real tricking. We need to, if there's a pattern, all the medical teachers need to identify. These are the things that has to be identified when you need to sit with them, a student, or at least tell the student, or give a note to the principal, as I've experienced in the medical college in Mysuru, where principal would tell them, okay, this person has been attending, score has come down drastically, so please have a session with the student and see what's happening. Some of them may have come because the parents didn't force them to it in Indian situation. So there are several issues like that. So I wish that you give that kind of a training to your own medical educators, so that would help them to identify people and refer them to the appropriate persons. Yeah.
Thank you, Sam. A quick comment from Dr. Anjali, and then I got a couple of questions here as well. You're mute. You're mute, Anjali.
Okay, Dr. Angie was talking about prescriptions. I would like to add more on that. It's definitely convincing patients to take medications. It's a very tiring job here. People does not understand. There are a lot of myths associated with medications. People think that antidepressants are addictive, that is going to change their personality. Once started, it cannot be stopped. It might change the way they are working. It might change their behavior. Many myths are there. To add on to that, when these people go to a pharmacy for medicine, the pharmacist will make a comment, "Oh, you're taking this medication. Oh, you should not take it." Then we have taken almost half to 1 hour to convince the patient. This pharmacist will just pass a comment without knowing anything about the medication. He'll just pass a comment, "Oh, you're taking this, please don't take it." Then they will come back again, "No, I don't want medication." Again, it is a tiring job for us to again convince them. And also some rare aunties or uncles will make some other comments: "Don't take such medications. You will not get a good partner. If someone know that you are taking medications, you will not get a marriage, you will not get a good family, and if it is a parent, your kids won't get a marriage." These are the types of comments people are getting from society when they are prescribed with the medication. So it's a very, very huge task for us to convince people to take medication. And also definitely medications come with side effects, and this Google and other online medias and platforms give many false, rarest of side effects will be highlighted in the first, and they will go and search. They'll find, okay, this is the side effect, so I will not take. So hurdles are many, but still we try to psychoeducate patients, psychoeducate caregivers regarding the need of medication, and some will adhere to that, some will take medication for 1 or 2 weeks, then they will drop out. Again, they will come with a very major depression or active psychosis. Again, we'll have to go on high dose, may need admissions. So definitely in our area, it is a very huge task for us to convince people to take medications.
Yeah, thank you, Dr. Anjali, for that. I'm conscious of time. We have about 8 minutes. There are a couple of questions here. One question mainly in relation from Dr. Rajni Ramachandran. The belief that mental health issues, the idea that one's broken always is what drives the silence among professionals, what Dr. Angie spoke about. And what about productivity? How does this broken aspect play out in the Indian context? A quick comments from the panel, please, on this, starting with perhaps Anjali, and then to Sam, and then to Paul, and to Dr. Angie. You're mute.
Get the question. Can you repeat once again, sir?
Yeah, it's about the what Dr. Angie spoke about in terms of the silence among the professionals,
Oh.
and how what is it about productivity? People are more worried about the productivity of things, and how does the broken aspect of play out in the Indian context?
Okay. Definitely, people are concerned about the productivity. They worry if they talk about their mental health issue, they might be labeled as mentally ill. And there are some terms like crazy, mad, which should not be used. Such terms are used by people, and definitely they're worried whether they'll be able to carry away with their career. Will they be judged by their seniors? Will they not be given the opportunities they need? So definitely there is a silence among not only mental health professional or a health professional, in every field that is there, even IT professionals, every field they are silenced because of the fear of judgment, fear of being labeled as mentally ill.
Yeah. Sam?
I'm not clear about the question.
I think it was a generic question in relation
Yeah.
to the thing I've sort of. It was about whether people are frightened because of the productivity, or the kind of there's a broken angle in terms of how people manage to perceive this in the Indian context among professional groups.
I'm not sure whether Dr. Rajin is talking about impact
No,
of
because we have answered the question. I mean, I think I've sort of deleted the question here, really. So I'm just repeating the question to you.
Okay. And I'm not sure whether she was talking about me being open about it, how it is going to be impacting the impact that public. That's what I understood. So
Okay.
if that is the case, I think now there are lots of WhatsApp groups in India where people talk about different issues. But unfortunately, some of those things which is frequently forwarded things are the negative aspects of it. The positive aspects of how somebody has come out of it. For example, the suicide of that celebrity, which has impacted a great number of people. So if you see the comments that follows, and it's very kind of disturbing. So that's what makes me feel that are we by keeping it open, are we taking in the right spirit, or is there any means by which we can censor these things, or should we censor, or not having censure, will it make a difference? I think that's then the upcoming psychologists or the psychiatrists to see how it is going to impact, because I get disturbed by several comments which that comes in open.
Thank you.
Yeah.
Quick comment from Paul and Angie.
Yeah, I mean, it's really difficult because I think, to me, it's about actually having that conversation and opening it up. And yes, you will get some, if you want to call them copycats. I remember a few years ago, there was a young, I think, male pop singer who jumped out of a building in Hong Kong and killed themselves. And subsequently, there was quite a few more suicides similar to that. We used to get that in the hospital as well. We'd have someone who committed suicide, and then there might be a spate of attempted suicides afterwards. So it's not uncommon. I just think it's perhaps more on a Instagram, Twitter effect nowadays. Maybe it's a bit more open and more people see about it. The point of just about the medication use, I've often used the analogy that with people that if you broke your leg, would you use a crutch to help yourself walk afterwards? And they usually go, yes. Well, then why don't you use a medication to help you get through this? Because it's just a medical crutch at the moment. You're not using it for life. And the other thing, just to say, I think that question was about, once you've had mental illness, are you broken for your life, and can you not continue? Yeah, I've been depressed 3 times where I've needed care. I've had cancer twice. I'm still going. I'm not going to be broken. It's partly up here, These are things that come at us all the time. It's having that positive, and not everybody will, don't get me wrong, but it's trying to have that positive view about things and move forward. And one final thing, Angie, you mentioned there about having sort of humor about things and how that is sometimes helpful. I mean, I I've said this to a few people, you know, I've had bowel cancer, I've had mouth cancer, I just need the stomach cancer now and I've got a full set. And people go, oh, don't say that. Hey, come on, just get on with life. It can happen.
Thank you, Paul. Angie?
So final comments from me. From what I understood from the question, Raghu, was I think you have to realize the impact of your mental health situation on productivity, because invariably it is going to be affected. And I think it is important to, you know, it's not always possible, but there is no point in continuing to reach a stage where you're no good to anybody, yourself or your patients or whoever you're working with. And so I think it's important to take that time out much earlier in the journey. Now, it's a difficult one, because where do you take time out? But I have the saying that I read somewhere, which said, how do you fill someone else's bucket when yours is empty? And I think that's very profound. I can't really help somebody else if I am not being able to help myself. If I have nothing to give you, then I'm not really doing my job to the best I can. And just on the comment about camaraderie and humor, I think one of our biggest reasons for increasing mental health is this, right? I think this is it. And I'll give you a little scenario. So I walked into the doctor's room the other day, and I had 4 trainees, which is a bit of a, you know, a novelty to see 4 trainees sitting in one room. And they were sitting there, and I walked in. One looked up and said, "Hi, Ms. Doshani," and the other ones just ignored me, probably because they don't even know who I am anymore. And they just continued on their phone. And I went there to get a specimen, so I just did my own thing. And I was there for 15 minutes, and not a single person spoke to each other. They just sat on their phone, doing whatever they were doing. And I remember back when I was a trainee, Friday night, so I trained at Liverpool. And Friday, 5 o'clock, we were all out. Whether you drank or not didn't matter. You were all out in the pub, you know, and even if it was slagging off your seniors, you know, talking about colleagues, whatever it was, talking about what your weekend plans were, it was just a good way to de-stress. And now I don't see any of that. We come to work, we do our work, we whinge about it, and then we go home. And there's no that camaraderie, that humor in what we do. And I think that's a big part of our life, right? Yeah. So I just think, you know, we need to reevaluate what is important to us.
I think that's an important point. I think on this World Health Day, I don't have to say this more, there is more to life than our mobile phone. Is a clear message here in terms of how we actually prolong things. There is also an encouraging comment from Dr. Raghu Raghavan in terms of the conversation that myself and Paul had in relation to our own cancer scenarios. Thank you very much for that. I think I wish more people actually would talk about it, whatever the condition is, because obviously it is not just cancer, it is not just heart disease, it is not just diabetes that is seductive. All other types are also seductive to talk about. And I think it's important that we encourage everybody to commonly talk about things. And one of the most important things that all of you mentioned in terms of having that conversation going, having that connectivity, having the ability to actually try and express our emotions and thoughts and feelings to each other, and to actually support each other in whatever shape or form. And I think that is the key message that we have on this World Health Day of 2022, where we discuss, and there is no health without mental health. An important point that Ranji mentioned is also the kind of proactiveness, the proactive conversation. And I think that is very crucial. And I think it is not just a stimulus response. And I think it's more important to life than just responding to questions or than just responding to texts and other things. So I think there is a challenge in front of us. There are clear messages for us to actually take on board. There are some simple solutions for us to actually follow. I'm sure this medium, this path, this space will continue with better and richer conversations on the same topic in the near future. So Thank you, MeHeLP India Foundation, for hosting this. And I very much thank our distinguished panelists, Dr. Angie, Mr. Paul Illingwoth, Dr. Sam Manickam, and Dr. Anjali Viswanath. Thank you for your valuable time and appearing on this webinar and for this important discussion. I'm sure we will be in touch again soon for more of the discussion on various other topics. Many thanks for all of you who have joined us for this and also for your questions. Let me just say, self-care, kindness, mental health awareness, mental health literacy, and that taking the deep breath and understanding is very crucial in promoting our health and well-being. There is no other medicine better than understanding our own essence of breathing and understanding what things are. So that is the best note on this World Health Day 2022. There is no health without mental health. So thank you very much indeed. Have a good evening.
Okay, bye. Thank you, Rick. Bye. Bye.
Thank you. Bye-bye, everybody.